Hello to all of our CalAIMH members and future members. We are so excited to provide you a video interview with Dr. Mona Delahooke, who is one of our leaders in the infant mental health field, an author, a practitioner, and a CalAIMH member, a CalAIMH inaugural member. So we're very, very proud of her. What I'm going to invite you to do is pause the video so you can read all of the highlights of her career. I don't want to spend our time reading her outstanding background to you. And I do want to highlight there's a link to her website, www.monadelahooke.com, where you can get information about the amazing things she's doing. Her two publications, which have been groundbreaking and have really opened our eyes in the field to think differently about social emotional development within the early intervention community specifically, but I think this clearly transfers to mental health, speech and language, all early care and education. All of us can benefit from this book. And Beyond Behavior, which has just launched Dr. Delahooke into quite a realm where a variety of people are excited and learning about this powerful book that connects current brain science to what we see in our kids. And from here, I'm going to stop sharing my screen. We're going to jump to the side-by-side where we are here to talk about your work and your passion and what we've learned about the brain and how you've put this together in a book that makes it accessible to all of us. So first, thank you. And I want to
thank you for having me. It's such a joy.
Thank you for being here. And start with what motivated you to take on this project.
Yeah. Well, really, the motivation had been coming for about 2 or 3 decades of working in the field. So, as you know, along with you, Dr. Stroud, I decided to specialize in infant mental health over 2 decades ago, when after I'd been in the field as a general psychologist, working with teenagers and adults for about a decade, I decided that toll it was taken on me was big, and I wanted to go towards more of a prevention model, towards something that I could go at the end of the day and say, wow, I made an impact on how this child is going to be 10 years from now, rather than looking back and, for someone like me who's very sensitive to human suffering, say, well, I wish I could have spoken to those parents when that child was 3.
Yeah.
So I enrolled in a couple of infant mental health training programs.
So let me just jump on that one.
Yeah.
So, no surprise. Are you saying you didn't learn infant mental health in your traditional psychology program?
Oh, so glad you asked that. No. In my traditional psychotherapy program, it was from the neck up, right?
Right.
Thoughts and cognitions, behaviors. And really, I'd say my assessment courses started at age 5. So I did not have any infant mental health training in my college Ph.D. program. That's
so
correct.
A lot of us who have moved to infant mental health, we really are relearning. We're building a new skill set to our existing skill set. We learned a lot. I'm also a psychologist.
Yes.
We learned a lot in our school, in our clinical field, but we really didn't learn the nuance of early development and how the infant brain is just expanding exponentially in its capacity to learn and grow. But you take it from there.
Absolutely. And we did. I mean, we learned about Piaget. We learned about Freud's levels of psychosexual development. So yes, we learned about Winnicott, who was amazing, who talked about there's never just a child, there's always a mother and child, there's always 2. So we had smatterings of that. But for me, the powerful change in the way I viewed development happened on an intersection of 2 things. One was the theoretical framework that I learned from Dr. Stanley Greenspan and Dr. Serena Wieder in the DIR floor time model. And they really were pioneers in the 70s. They developed a sense of a developmental trajectory that infants go through, called the stages of social and emotional development. And those were just eye-opening for me when I understood how development unfolds from the body up, because an infant, you can't talk to an infant and ask them how they're doing, right? You have to observe their little body. And so I was lucky enough around that time in the late 90s to be asked to participate in a clinic at USC, a behaviors in babies clinic. And Dr. Marie Polson, as you probably know, invited
another
me.
CalAIMH member. Thank you, Marie. Yes.
Thank you, Marie. And Dr. Karen Finello taught the course at CSPP. So I audited that course, and I was in the hospital every week at this clinic where we had an OT, a PT, a teacher, a pediatrician, an educator, mental health. We had all these disciplines sitting around a table talking about the same baby, the same toddler. And that's when, oh my goodness, I just saw so many crossovers. Like, oh, what is sensory processing, for example?
Yes.
It's how we take in information from the world. Was sensory processing and sensory over or under reactivity ever talked about in my own graduate training? No. So I just feel like I was so blessed with this intersection of DIR and infant mental health that allowed me to understand that essentially the difference between what we call top-down behaviors, which is thinking, cognition,
right.
You know, what we do with our brains, and body up. Mm-hmm. And I should also give a shout out, she's probably a member as well, Dr. Connie Lillis.
Yes, she is.
Okay, so, you know, we were all studying this stuff together early on many years ago and realizing that our current models are not sufficient to understand and really help support parents on the floor with children, with their babies.
Yeah.
And
I just want to underscore how you talked about the people at the table, OT and PT and psychology and also education and nurses. And that is the infant mental health community, folks. We get caught up in the term mental health, but infant mental health are all of us who support the social emotional health of little ones. And we really want to make that clear at CalAIMH. We are a transdisciplinary community. You don't have to be a mental health professional to be in this group. Actually, we need you if you're not a mental health professional, because that occupational therapist teaches me something, and that educator teaches me something. And there's this wonderful cross-disciplinary, transdisciplinary learning that not only do we benefit from, but so do the parents. Yeah,
absolutely, absolutely. And when we're all speaking the same language to parents, it's about social emotional development, because we're all dealing with social and emotional development, even though our discipline might have focused on a certain part of development, like motor development, or you know, our internal systems. We're all dealing with social and emotional development at all times anyway. So yeah, I welcome OTs, PTs, preschool teachers, and everyone to CalAIMH. I mean, it's really, it's an inclusive group, and we need all of us together. Yeah.
Definitely. Yeah.
Yeah. And so when you asked why, you know, what led me to write the book and my passion, it really was after I was in practice for quite a while, and I was implementing what I learned as an infant mental health specialist, especially something that came in as well through my DIR training was an understanding of the autonomic nervous system, where I met Dr. Stephen Porges and his work. Yeah. And so when I was integrating these new kind of theories into helping parents understand and helping IEP teams, for example, understand development, especially behavioral challenges, I found that really we were still looking at behaviors as the whole thing. And so what I was trying to do in teaching essentially during this time was for us to move away from just looking at behaviors, because as you know, I call them the tip of the iceberg, to what's underlying the behaviors. So the underlying behavior piece is the most interesting part. And that's where we find all that information about how we really help a child. And so that culminated my explanations over the years. I felt would be kind of easier sometimes to hand over a book than to spend 5 hours talking about it. So I wrote a book called
Okay,
Beyond
there you go.
Behaviors.
Yeah,
Yeah.
great. And just I know we don't have 5 hours, but kind of tell us a little bit about what's behind the behavior. What are some things that are below that, under the water, when we think
under
about
the
iceberg?
waterline? Yeah. Okay, so let's think about under the waterline. First of all, let's think about our current model of how we view behaviors, right? In our early intervention services, in our education system, and for many parents, of course. And by the way, whenever I talk, this is always a no blame, no shame deal.
Sure.
I am not intending any sort of a criticism of any sort of parenting technique or way you practice based on your own identity, your own parenthood, your own culture. So it's inclusive, and I don't mean to criticize. This is just a new lens that I've proposed. So just to say that I honor everyone's individual choices, of course. But currently we have behaviors really looked at as either good or bad. And oftentimes, including in our DSM model, you have a checklist of a certain amount of behaviors, then you have this disorder, right? Yeah. So it doesn't equal a good thing. Behaviors are kind of looked at as, if you have enough of these behaviors, something's terribly wrong with you. In our education system, if you have a long list of bad behaviors, then you are known as non-compliant. Yes. So in education, it's compliant or non-compliant. In our general society, is kind of behaviors are either good or bad. And the shift that I describe in the book is really looking at behaviors from not a disorder lens, but adaptations of the nervous system. And so really valuing behaviors for the incredible information that they give us about the child. So it's a lens shift from saying, oh, we have to get rid of behaviors, to no, we really have to value. The more challenging, the better. We can find out so much about what that child needs. It's really huge.
Yeah, it's sort of like, okay, so I think about the optometrist and they shift the lens, right? For anybody where it's got to go like 1 or 2 and you have to decide which is better.
You're always figuring out which one is which one's
really
better.
Different. I don't know, they look the same. But what you're suggesting again is we're shifting our lens from that behavior is bad, or we don't like it, or I don't know how to understand it, because sometimes the behaviors that are bad are behaviors that we sometimes as adults can't make sense of. Sometimes, not always.
Yes.
And so what we're shifting to is, no, that behavior is telling us something about the child's internal state and how they manage. And in a way, what a gift is what I'm hearing in your transition is like, thank you for gifting me with that behavior that tells me you need a different response from me, or your nervous system is struggling. That's good data, because I like data.
Oh, I do too. But I love the word gift. Yes, that's exactly what I'm saying. I'm saying that we can value behaviors for what they tell us about the child. So it is a gift. Now, as a parent myself, I remember when one of my daughter's behaviors were not interpreted as a gift, either by anyone on the outside or myself. And I was like, oh no, what have I done wrong? Because we have so much blame for ourselves as caregivers, and we think that we may have done something wrong. But when we shift our lens to, especially the more challenging behaviors, the ones that we would consider those fight or flight behaviors, when we shift our lens to viewing them as adaptations that we make subconsciously, that a child makes subconsciously, not out of willful misintent or the desire to be, a troublemaker, right, but out of this drive, this instinct to protect oneself. And so now we move to the lens of safety versus threat.
Right.
And that lens just gives us a whole new tool chest, a whole new tool chest for our interventions.
Yeah. And I'm with you on the safety versus threat. We've had the gift of really learning from giants like Stanley Greenspan and Serena Wieder and Connie Lillis and Stephen Porges and Bruce Perry and Dan Siegel and on, right? So we've had that lovely gift. Not everyone has had that gift. And when you say safety threat, I want if you can sort of help explain that for practitioners and even parents on the watching this. What do you mean? What am I looking for? What's that about safety threat? Yeah.
Oh, great question. Great question. So what does that mean? Well, there is a word that Dr. Porges developed, essentially a concept that he developed, that he introduced in the 0 to 3 journal in 2004 called, yes, 2004.
Okay, don't believe you.
Yeah. Dr. Stephen Porges wrote a journal for 0 to 3, which is the journal for it was the National Association of Infant and Mental Health.
Center.
Yes, something like
it was too long. 0 to 3, we love you.
Yes.
Thank you for changing that.
Yeah.
Go to their website.
Of which
they have
you were a fellow.
Content. Yes,
Yeah, you are. And so that in that journal article, he introduced the word neuroception. Neuroception is a term he coined for the subconscious detection of safety and threat that all human beings have, that works on our subconscious level, meaning that we're not aware of it. We're not aware of our beating heart or our stomach digestive processes, but it's all happening in the background, similar to a TSA agent. Think of a mini TSA agent, the back of our child and our own bodies, always making sure we're safe.
Okay.
So when a human detects threat, it's very personally determined. Threat from a little mini TSA homunculus could be a smell. It could be a sensation from the inside, a tummy ache. It could be a toothache. It could be a virus that's kind of starting to develop in the infant or a toddler, where all of a sudden you see them doing these funky behaviors, these challenging behaviors. And what is really happening is that neuroception is picking up danger or threat, and the body's natural response to picking up threat has to do with mobilization. And as it gets increasingly more distressing, the mobilization can look like the sympathetic nervous system driver, fight or flight. So this might be like, it seems like a child out of the blue will hit someone.
Yeah.
But it's not really out of the blue, because there's an instinct in the body to move. And sometimes the way toddlers or children move is through, unfortunately, attacking.
Right.
So safety versus threat means the perception that's individually determined by each person's body to sensations inside of the body or in the environment, including other people. So it could be interoceptive, which is inside the body, or outside the body.
So I just want to restate that, because that's a lot. It's pretty complex. Make sure everybody's tracking. Yeah. So we're talking like below the neck. I'm not even aware in my brain what's happening. Like below the neck, my physiology, my whole body is responding to external or internal stimuli, which is I perceive as a threat. I'm at risk now. And so my body, even before my brain kicks in, is going to do something. You said it's going to activate mobilization. It's going to activate. There's going to be an action. And that action may or may not be perceived well by others, but it's automatic, it's unconscious, it's below the neck. I did it to protect myself, not to make the teacher angry, but I did it because I didn't feel safe. That's what the lens we have to now shift to and understand. Yes?
Beautiful. That is the soundbite for this whole clip. Yes. Thank you. I love how you translate it. Yes. Translationally, that's exactly what it means. We now have a new understanding of that child doing something that we think is willful or non-compliant, or again, a behavior that's, maybe they learned this. I hear so many ideas from well-meaning preschool teachers and daycare owners, like maybe they learned this at home. Maybe this is a learned behavior. Well, maybe it's an instinctual drive to protect oneself. And I think it's worth mentioning here, because many of us work with children who come from either toxic stress or trauma backgrounds, that if you have these experiences of perceived threat in your history as an infant where you're especially vulnerable. For example, if you hear loud voices that are unpredictable, or if you are suddenly experiencing some sort of physical shift, if you're moved too harshly, or if you're mistreated, or if you're neglected, your brain starts to pick up threat more easily. And so many of our children that we work with who come from high-risk environments have what Bruce Perry calls a sensitized stress response. And what that is that they're more apt to be triggered by seemingly innocuous things. Does that make sense?
Yes,
And so
yes,
you might see more
yeah.
behaviors in certain children who are more
Yeah.
vulnerable.
And I think this is important for folks watching to be aware of, because I hear outside of the lens of infant mental health in just casual conversation, we again are struggling with this idea that babies don't remember. We still have that narrative that children are resilient. Oh, bad things can happen, but they'll be fine. They don't even remember. And we now have a great deal of information around the body does remember, and we may not even be aware of the traumas that we've experienced, but our body certainly is aware. So we're back to these really early experiences that can happen in utero, that can happen in the first month of life.
Yeah.
When a child is in a situation that is not safe, and they're quickly moved and placed in a very safe environment. However, they still have these body-based responses that we can work with and shift. And I think there's a fair amount of information about how to do that. But I think we also have to respect the function of that behavior versus pathologizing that behavior. And I think that's part of what we're doing with our shift of our lens, is really starting to understand what this child is telling us versus turning this into a label or a bad thing.
Exactly. It's so important. It's if we understand how profound what you just said is that not understanding this contributes, I really believe, to the school to prison pipeline. Because we have to understand that these behaviors that we see in children that are actually adaptive and toddlers trying to save their lives, they don't know why they're in a fight or flight response.
Yeah.
And think about it. If you're doing something that your body compels you to do out of survival, and then you get punished for it or secluded for it, like timed out for it, it makes you feel hopeless as a human, because you need help. You need social engagement. You don't need social disengagement. And so it's almost like our systems are backwards. The children with the most challenging behaviors need to be seen as the most vulnerable children. And we need to compassionately understand that those children are not actually needing more discipline or more consequences. They're needing more love. They're needing more engagement.
Wow. That is a huge shift. That's a huge shift. And when we think about the developing brain, we can begin to understand. I have this developmental background too, that there's developmental need. There's something in the brain that didn't develop in the way that we would hope that the child could support their own safety threat response. So we need to provide love and resources and compassion to build that part of the brain and build that part of the social emotional perspective of the child. Would that be a fair restatement?
Absolutely.
Okay, great. And then
those
there's
networks.
Yeah, those
because
networks.
The brain develops it through the layering of networks, and it's never too late. It's never too late to build new networks for children, but our little ones are so vulnerable to those networks getting offline. And so that's why we're trying to, through all of our infant mental health organizations, trying to get public awareness early in the first few years rather than later.
Yeah. Now, and as we speak about more compassion for kids who have challenging behaviors, disruptive behaviors, I like to say behaviors that we don't like. They're just behaviors we're not fond of, but they are survival behaviors for the kiddo, right?
Sure.
The back of my head is sort of screaming the narrative, well, we're reinforcing bad behavior. So what do you want?
Yes. And okay, I so understand that. I felt that way too. and it kind of goes against our instinct, I think, as adults and as parents. Like, you want to raise your child up right? You want to do a good job.
Yes.
And we're programmed to think that if we reinforce a child for doing something bad, that they might do it again.
Right.
So I get that. And I don't judge it, because I felt that way too. until I found out a little more about understanding that we have to know about, again, underneath the tip of the iceberg, if this is a survival mechanism, we will know that the bad behavior equals vulnerable nervous system, instead of bad behavior equals a child who needs more discipline. And when we shift our lens to see this child whose body, not mind, whose body is giving the information, because remember the networks that come up from the nerves to the body is like 80%, and it's only 20% from the brain down. The body is getting feedback that it needs to protect itself. So we need to counterbalance that feedback to let that child know, you're safe. You're safe, sweetheart.
Yes.
I'm with you. And that's the whole process of what we call co-regulation. So the strategy turns from discipline to co-regulation. And it's so powerful to see when a child is properly co-regulated, those bad behaviors fall away on their own. There's no reason for them anymore. Yeah.
Beautiful. Thank you so much. So I want to kind of just think in our last 5 minutes together about how we can support parents in making this shift. What would you want to say to parents? What would you want to say to providers to share with parents? What's a good way to shift my lens? Because I think too, as a parent and as a person, I'm full of my own experience and past messages and, old narratives, cultural narratives about raising children that are a part of me. Many of us are. You sort of said, I had that feeling too, I had to struggle with picking up my crying baby when she was young around. Am I spoiling her? Because I had gotten those messages. And of course, I've learned that our babies need response. But we are caught up in some of those old ideas and wanting to do right by children and be better. So what might you want to say to parents, and as we're all working on shifting?
Well, you're just so good. I love how you framed the question, because the way you framed it was compassionately. So that's the first step. The first step is realizing that we have ingrained into us different ways of believing and thinking about raising up children. And I think absolutely what you just said about, okay, there's a conflict potentially here, because our instincts and possibly how we were raised, I know how I was raised, was with pretty much looking at behaviors for what they're worth and thinking that the parent had to mold the child's behaviors. So first of all, putting our hand on our heart, saying, oh, this is okay, this is all right. I'm not a bad person for feeling this way, because this is how our culture has trained us.
Yes.
Now we have a choice. And again, the choice must be, and I think it can be, synchronous with your faith tradition, with your culture, with your family values. It has to be synchronous with that. It cannot overtake. So we have to put that first, I think, compassionately, that we value our traditions in each family, and we're all going to have a different tradition. So we value that. But if we can just overlay a little bit of neurodevelopmental brain science to that, this is what it might look like.
Mm-hmm.
The next time you see a child doing a behavior that you think is a bad behavior, or something that is challenging to you, or you think, oh, this is not a respectful behavior, something like that, first ask yourself this question. Is this a purposeful, willful behavior, or is this a child who's having a stress response and who kind of seemed to do this or say this bad thing out of the blue. That's a good signal. If it happens fast, and if it happens during, especially like during a fast transition, or something's going on in the child's life, or maybe it's right before dinner time, or maybe it's when you're saying goodbye to a parent and dropping off grandma somewhere. Think, is this a purposeful behavior, or maybe is the child's system that is the system of protection taking over? And then we might draw on our own compassion for the child and realize this is not a moment of teaching or consequencing, but this is a moment of engaging.
Mm-hmm. Mm-hmm. Okay. All right. Great.
Yeah.
Great.
But I know it's a big lens shift. It's a big shift. It's a big shift. And maybe we do it in small pieces, right? We don't have to do it all at once. But I think when I studied the work of, when I was writing the book, I was also taking for myself some courses in person from Dr. Kristen Neff, who has done a lot of research in self-compassion. She's like one of the world's biggest compassion researchers. So I spent a couple of weeks with her on these retreats to garner self-compassion for myself, because I know I'm very hard on myself for all the mistakes I made as a parent, and I made many. And I think that when we understand that compassion for ourselves calms our own nervous system down, then we are able to be more present and do this co-regulation thing. So rather than coming away from hearing this kind of a talk and saying, uh-oh, I've been doing it all wrong, you can, what I hope you'll come away with is, oh, I did the best I could.
There you go. Yeah.
And I am okay. I love my child. And here's some new information I might integrate, but I'm okay. I did the best I could.
Right. And I just want to add, I want to add, well, this is, it's going to be a shift. I think about all the developmental information we have learned over time, like back to sleep movement, it's sort of like, hello, that reduces SIDS. It's a good strategy, yet I survived sleeping on my stomach. I mean, I'm not suggesting you do that, but so there's a generation of us that grew up in a different mindset. And now that we have new data and information, we can shift the way we support child development. This is wow, how exciting. We have new information. We can shift the way we support child development, and just remind parents that, we're in this current COVID pandemic. And so we can expect our children to have less tolerance, I think, for things like change, for things like trying something new sometimes. And so be patient with yourself and your children. They might be a little more reactive, a little more antsy, and this is where more love and more support and more compassion and more snuggles and just more nurturing, I think, is needed for all of us, and particularly our little people whose brains aren't big enough to make sense of everything that just keeps changing. I mean, I'm confused. So I can't imagine how you can be 2 years old and 3 years old and make sense of all of this. So,
absolutely. The better we take care of ourselves, the better off our kids will be. So.
Yeah, I know we have limited time with you, so I want to say thank you again. I want to tell everyone who's watching that we welcome you to join us at CalAIMH. Please feel free. We need your voice. We need your transdisciplinary perspective. And if you have a suggested video interview you'd like us to do, if you have a resource that you'd like to share with us, join and be a part of the community that's trying to make change. So again, thank you, Dr. Delahooke. Make sure to go to her website and make sure to buy her book. We appreciate
thank you so much for having me.
Of course.
Take care.
All right. I'm trying to stop recording. Yes, we're